can't say too much because I only have 15 minutes and 5 minutes for questions. So I was trying to kind of to focus on the essential. It's, for the most part, gender-neutral presentation. It just talks about when is best to sleep and how do we know that we sleep enough? And I'll leave it at that. So there's a very, very simple equation that sounds too simple, and when you first hear it, you almost will tune it up because it's so obvious. But it actually has a lot of complicated science behind it. That at any given moment, the probability that we will sleep is determined by forces in our body that drive us towards sleep and forces that drive us towards being alert. And so let me tell you about it. Right now, I'm going to talk about 3 forces. You have 1 in favor of sleep and 2 in favor of staying awake. So here they are. So first we'll start with 2 that are considered to be the 2 processes that regulate sleep per se. One of them is the sleep drive. So what happens with the sleep drive is that it's essentially like hunger. The longer time passes since you have last slept, the greater there is an accumulation of byproduct of energy expenditure in the body, and your brain. So basically, what you see here is that as we are awake, there's an accumulation of chemical in our body that builds up and becomes the fuel for sleep. So this is part of the teeter-totter that's towards sleep. It's kind of like hunger. The longer time that you go without food, the more your body is going to prompt you to search food because it's a basic need of human beings, right? So that is part of the regulation. When you sleep, energy restores and the sleep drive decreases. So what you see in this figure that was written for a PC and now it's trying to be presented on a map, basically the drive towards sleep is towards down, and as your day goes by, you increase sleep, and when you sleep, you decrease the sleep drive. So this is a very basic function. Now comes the next piece, which is from evolutionary perspective, it's not a good idea for us to stay asleep during the daytime because there's too many. We should be searching for food, gathering, hunting, and making sure that we're alert and that predators don't devour us. And so as our body accumulates this need for sleep, the body has another mechanism that makes sure that the balance in the teeter-totter is still in favor of staying awake. So it starts sending alerting signal of magnitude that slowly increases. So the more you see the sleep driving for sleep, parallel to it, you see that the circadian clock, it's a biological clock that generates alerting signal that becomes stronger and stronger while it's still day. And a little bit after it's dark, it starts coming down. The body then detects that is a good opportune time to sleep because at this time you have a good, healthy appetite for sleep. Your sleep drive is very strong. But from the perspective of the clock, it's okay to sleep. So it's kind of more permitting to sleep. So it starts decreasing. So the balance starts being in favor of the sleep. And so then you would sleep. So that's basically how these 2 things work together. It so happens that scientifically we measure that sleep clock by measuring core body temperature. So it's not the temperature on the skin and how you feel cold or hot. It's more that constant temperature that we warm-blooded animals have is not that constant, and there's about 1.5 to 2 degrees Celsius of difference across the 24 hours, and that minute difference actually makes a big difference in terms of when we sleep and when we don't. And that clock, it does not look like this, and it doesn't look like a digital clock. It's basically a sequence of chain reactions in the brain that takes approximately 24 hours to happen. And so that low point in our alertness is the minimum of this temperature of our clock, temperature rhythm. And I'm going to refer to it in the next slide. That's why I'm orienting you now. And approximately 1 to 3 hours after that minimum in our core body temperature, we naturally wake up because now the clock is saying, alert, 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 wake up. And our sleep drive has been satisfied, so bang, we wake up. That's not the whole equation. There's a third process I'm going to get to, but sometimes there are some people for whom the clock is off society. So, for example, if, let's take a hypothetical human being who has a normal to society sleep phase, their temperature minimum or that low point happens maybe around, goes to sleep at 11, wakes up at 7, this ideal 8 hours that somebody says is an ideal, and maybe it's 4 o'clock in the morning and 3 hours later the person wakes up. There are some people for whom this whole minimum, the whole clock is actually shifted to a later time. So for that person that is in this block to wake up at 7 would feel like for the person in the block above to wake up at 4:15. Doesn't feel that good. At the same time, it's, if they try to go to bed at 11, their clock is still say, stay awake, and so they can't shut their mind off. In fact, they feel very energetic. And then when they try to wake up and go to work at a regular time, they find it extremely difficult and they struggle, and sometimes in extreme cases they're late to work, and some teens have to drop out of school or drop out of college because they can't do that. On the other extreme, so we call these people delayed sleep phase tendency or having an owl tendency, like night owls. And the other extreme, you have the people whose temperature minimum actually happens much earlier. I gave you a very extreme case. It's hard to find these cases. But let's say somebody whose minimum already happens at 1:30 at night in the morning, right? So 3 hours later will be 4:30. After that, they can't sleep anymore. So they're up. They would like to. Now they retire. They have time, no obligations, but they can't do that anymore, right? And that has to do potentially with their clock. So it's difficult for them to stay up in the evening. They go to the movies or to the theater, or they fall asleep. They can't enjoy it because their clock is already on the downside with the alertness, and they've been up since 4:30, so the equation is in favor of that being asleep. So they doze off next to the TV, and then they wake up at 4:30, and then they can't sleep anymore, right? So these people have an advanced phase, or what we call lark tendencies. The good news is that though these tendencies are extreme, most of us are in the middle, like 80% of us are in the middle, 10% are at each end, let's say. It is possible for these 10% at each end to live with society, but they need to shift their clock somehow, and they need to do things behaviorally that will help them keep them there. So the timing of when you go to sleep needs to be in sync with your clock. And if your clock biologically you were born with a tendency that's different than what society is, then there are some measures that you need to do to bring you there and to keep you there. And the most important thing, for example, for a person with a delayed clock, is to always wake up at the same time. And people who are delayed clock, it's hard for them to do that because finally on the weekend they can't sleep in, so they want to sleep in. Why not? But if you do that, that's fine. It's like you are doing the best you can for today, but you're ruining the whole scheme because you're maintaining yourself being not living in sync with your clock. So the light is very potent. So if we want to take a clock and to shift it to be earlier, to advance the phase, so bring that temperature minimum to an earlier time, the key is to always wake up at a certain time and make sure that your retina, your eye gets light. Open the curtains, open the windows, ideally go outside for half an hour on a regular basis, do a morning walk. It's perfect. Then you can keep yourself on that schedule and live in sync with the world, even though you basically moved your biological clock to be in sync with the world, okay? So if you then expose light at that time and have more darkness and subdued evening light, then your whole rhythm will move to the earlier time and you'll be happy. And the same thing is true for the other extreme. If you want to have a person who's really a very strong morning person to be a little bit later, then you would have them lots of bright light in the evening, and then dark light in the morning, and then the rhythm will shift to the other direction. So that's basically, it's much more complicated. There's lots of science behind it. There's a whole field that's outside of sleep research that's called the circadian rhythm research area, and it's a complete different field, but the two fields talk to each other because the regulation of sleep is so closely tied with the regulation of that clock. So it is also important for other reasons to always have the same wake time, because that makes that clock send very robust signal. If you confuse the clock, sometimes waking up at 6 and sometimes waking up at 11 in the morning, then it's essentially you're moving 5 time zones every weekend. You're basically traveling. It's called social jet lag is how we call it. It's basically what you're doing. And social jet lag doesn't make for a very robust signal from that clock. So it's healthier to maintain a robust signal, to be very strict about when you wake up. We can tolerate an hour, 2-hour variation, but not huge variation. And the more abnormal your biological clock relative to society, the more you have to be strict about when you wake up, unfortunately. The less you like the idea, but you should be doing it. It's good for you. But then we have a third process. And what happens is that even if you go to bed at a time that's right for your clock, and you are very hungry for sleep, you have not snacked on sleep by dozing off next to the TV or taking long naps in the afternoon, but imagine in the old times, now you're in a cave, and the hyena is howling outside the camp. Well, that would not be a safe thing to do, to sleep right now, right? So the sleep system and the wake system are talking to each other. They are not one and the same. So if the wake system is saying there's danger, then the sleep system gives up. It lets the wake system take over. It can trump the sleep system. And it's biologically adaptive. Now, modern-day hyenas take many different shapes, right? It could be, I have to do a presentation tomorrow and I'm anxious, I'll make a fool of myself. Or it could be, I have to catch a plane and I'm afraid I won't wake up. Or it could be, I'm worried about something or another and there's no shortage of things we are worried about. Those are threats for us. The body does not distinguish between a physical threat and a psychological threat. It's a threat. And with the same system helps to preserve us from threats. It gets activated and then we can't sleep. So bottom line is, the best 3 things we need to do in order to when to sleep. We want to go to sleep when we are hungry for sleep. The sleep drive is strong. Our circadian clock, our biological clock, is our timing of the sleep period is congruent with our clock. And we are not trying to sleep when we're feeling that we are not in a state that's congruent with being asleep, right? If we are very anxious, we are very uptight. So our job is find ways to relax and then go to sleep. You can't expect that sleep will be the one to relax you, because without relaxing, you can't do that. So that's the when. So now I have 4 minutes to finish up talking of how much. So the bottom line, if you need to leave now, is it varies. It varies from person to person, and it varies across our life how much sleep we need. The important thing is you hear a lot of bad things can happen if you don't sleep enough. Your health indices, your immune function, your weight, your beauty, whatever. The reality is it's all in the balance. If you start worrying that you must sleep in order to do this and this and this and this, the more there's performance anxiety, then it is threat, and then you won't be able to sleep very well. Nonetheless, nobody complains when they are in love they don't get enough sleep. So that means that we all can function on less sleep if the motivation and the fun is high enough, right? So there are variability not only between people, but across our lifetime. If we're in a funk, we want to sleep more. And if life is too exciting, we don't want to waste the time sleeping, right? So it is really all in the balance. There isn't a uniform formula, but you do need to watch for some signs. So here is what's the signs of insufficient sleep. 20% of adults identify themselves as not sleeping enough, defined by feeling that there's at least hour difference. They would like to sleep at least 1 hour more than they are getting. The average sleep of adults aged 21 to 30 is 6.7 hours on the weekends and 7.4 hours on the weekends, suggesting that they are curtailing how much sleep they need on average because they are making up for it on the weekend, right? So there is a sleep need that's not fulfilled. Motor vehicle accidents can be related to insufficient sleep, and anybody who had to take the driver's ed exams for points or not is by now very well alert that it made it to the DMV education, that not sleeping enough has equivalency to being drunk. So that even moderate amount of sleep deprivation, like 28 hours of not sleeping at all, is equivalent to performance decrement that's equivalent to 0.1, which is being drunk, right, legally. So there is a difference between 28 hours of not sleeping at all, which we do in the experiment, and what happens in real life in which we chronically don't sleep enough on a given night. And here there's some interesting statistic that if for 2 weeks you sleep only 4 hours a night, then it is equivalent in terms of how much decrement in performance you have that if you have not slept for 2 hours at all, 2 days at all. And if for 2 weeks you are sleeping only 6 hours a night, it is, for people who are used to sleeping 8, it's the equivalent of 1 night of not sleeping at all. So there is an accumulation of sleep debt that does have an impact on your performance. And we are not that good about identifying what it is, how sleepy we are. We can be pretty bad judges of that. So just be alert to your level of alertness, and that will determine how much sleep you need to get. I want to skip this because we are running out of time. So I just want to say one last point, and that is there's a huge difference between being sleep deprived because you're not giving yourself or given enough time to sleep because of other demands, versus not being able to sleep because you have a sleep disorder, because you're unable to sleep because even if you try, you can't sleep. And that's where my clinical work begins. I'm directing an insomnia program, and that's what I do. I help people sleep better without taking medications. So I have an interesting and complex slide in here that basically means that people who can't sleep because they have insomnia feel tired and fatigued, but they're not that sleepy in the sense that if I tell them, okay, now go take a nap now, they won't be able to sleep. So, and then if you get people from all of this slide, I want to tell you about one experiment, and let's pretend that this half of the room has insomnia, and this half of the room sleeps well. And then I bring all of you people to the lab, and for each person, I find another person approximately the same age and gender. And I make if you took an hour to fall asleep, I'll make you take an hour to fall asleep. If you woke up after 2 hours and were up for an hour, I'll wake you after 2 hours and make you up. In other words, you have a simulated disruption of sleep that's exposed by the experiment, whereas you guys had a problem sleeping because you simply can't. Well, if I bring you to the nap, give you a nap opportunity, and you give you a nap opportunity, you'll be very different. You'll fall asleep right away. You'll take advantage of the nap. You won't be able to sleep. So it's not, you cannot conclude that all the scary things that happen to people with, who are deprived of sleep also hold true for people who have insomnia per se. So I'm going to leave all of this with just one slide showing you that there's gender and age difference in how much people suffer from having poor sleep. And you can see that the older you are, the more problems you have sleeping, and that it doesn't matter what age, there's a gender difference in that women are twice as likely to have sleep problems than men in terms of insomnia. So I'll leave the next slide just if you want any help with sleep or know somebody who needs help from sleep, and I'll open it up to questions.
Could you go back one slide for just a second? Thanks.
Yes.
Do you have any words of wisdom for people that are on night shift?
It is tough. Night shifts, we've not evolved to be on night shifts. People who are night people biologically have it easier. Night shift that is always the same shift is different than rotating shift. So, yeah, so 3, yeah. So if I had time, I have to run and see a patient at 3 o'clock, so I don't have time to stick around for hallway conversation, but there are ways to adjust, but I can't give you justice in the time that I have right now. Yes?
Is it true that teenagers' sleeping clock is different than?
Well, so teenagers have a behavior that makes them look like most of them are owls. Some of them are social owls and others are biological owls. The gene for being an owl tends to be expressed with puberty. So some of it is biological and some of it is social. How do you know the difference? Those who are social would adjust once they outgrow adolescence, and those who are more biological will have a harder time. But I listen very carefully when I see lots of teenagers, and particularly the month of August is very popular just before school begins. Yeah.
Yes. Is there a better time of day or a cutoff that you should take a nap?
That's better or worse?
So it depends for what. First of all, ideally, you want to take short naps. So 15, 20, at most half an hour. The longer you nap, the more likely it is to disturb your sleep. The closer it is to when you actually, so even if you just doze for 5 minutes at night, it's going to be more detrimental. So it's better to actually take a scheduled nap earlier in the day, like approximately 7 to 9 hours after you wake up is the way we typically recommend it, for about 15 to 20 minutes. Then it doesn't tend for most people to disrupt sleep. There are whole societies who have a siesta, right?
Yeah. So we need to stop.
Okay.
Thank you very much. I'm really excited to be here today to speak with you about optimizing the mind-body connection in women with pain. Pain is a huge problem in the United States. 100 million Americans suffer from chronic pain, and the incidence is increasing with the obesity epidemic and also as the population ages. So how do we treat chronic pain? In many different ways, ideally in a multidisciplinary format, but there's been what I believe is an over-reliance on prescription medications to treat chronic pain, and specifically on opioids. And so we see that in 2011, for instance, Vicodin was the #1 most prescribed drug in the United States, and that was really true for several years. And opioid prescribing trends have really increased quite sharply over the past 15 years or so, such that from the years between 2006 and 2010, OxyContin prescriptions increased fourfold. So the consequences and implications for pain and for women are greater for women, specifically because women have more pain than men. So women are 2 to 9 times more likely to acquire varied chronic pain conditions. So this could be migraine, this could be lupus, this could be fibromyalgia, this could be rheumatoid arthritis, you name it. There's just, women are biologically predisposed to acquire chronic pain relative to men. And once women do acquire chronic pain, they have greater pain sensitivity, intensity, frequency of episodes, painful episodes are more common in women, and the duration of pain episodes are longer for women. So pain is simply a bigger problem for women, is how I like to think of it. And there are multiple factors that play into why women have greater pain, and some of these factors influence pain perception. So I want to just talk about, just very briefly touch on what some of these factors are that explain some of the dimorphism for pain. And these include central nervous system processing, sex steroids, obviously different between men and women, hormones, the immune system, psychological factors. Women have more anxiety and depression than men do. Women tend to process information differently, and I'll be speaking more about that as we go along. Psychosocial factors, women are more likely to have a history of abuse, and this plays a role in the development of chronic pain, trauma and abuse, and then there are sex differences in terms of stress responsivity, and this plays a role in chronic pain as well. So all of these factors influence the perception of pain, and I really like that word, the perception of pain. So what I want to touch on now is, what exactly is pain? I mean, we all know it when we feel it. It hurts, ouch, you want to withdraw, you want to escape, you want to get away from it. But what is it? How do we define it? Well, the International Association for the Study of Pain is really the premier global society that focuses on pain, the empirical study of pain, and also the treatment of pain. And here's the definition that they give. I mean, it's actually, this is an abbreviated definition, but the definition is that pain is both a sensory and an emotional experience to either tissue damage that is real or potential. And so that is a really interesting definition, in my opinion, because of this emotional component. You really cannot separate the emotional component from the sensory experience of pain. And so observe that psychology is actually built into the very definition of pain. And this is important and powerful in terms of how we treat pain, and specifically how we treat pain without pills. So pain is actually located in the brain. There are very specific brain regions. We can image this with MRI technology. When a person is experiencing pain, there are certain areas of the brain that light up, and they're associated with the sensory experience. The sensory experience of pain There are cognitive factors. Cognitive processing is involved in interpreting this experience, and there's also emotional processing that are involved. And there's some overlap, but there's also distinction between the cognitive and emotional processing of information and how that is interpreted in terms of pain. Now, in terms of sex differences, women appear to be more attuned to negative emotional stimuli. And so that's really interesting when we think about a noxious stimulation and that is a negative input and how women might respond to that. And this is particularly true when estrogen is low. And so we see differences across the menstrual cycle, and we also see differences between pre- and postmenopausal women, so that when estrogen is low, women may be more vulnerable to interpret, to be attuned to these negative aspects. And to pain, this may play a role in dysphoria, in the expression of depression, and there's also implications for pain. So in terms of pain, I want to talk about pain catastrophizing. This is a really interesting psychological construct. You may be familiar with this. You may have heard about this. Pain catastrophizing, it's a cognitive and emotional construct. So it's comprised of 3 factors. It's when we ruminate about pain, it's when we magnify pain, and it's when we feel very helpless about pain. So it's both our thoughts and our feelings about pain. I like to think of it as sort of just going into the vortex. You know, you're suffering, you can't think about anything else. It's just really dark and negative, and we're sort of stuck there, feeling very helpless. And so this is important because there is a 1/4 century of research on pain catastrophizing. And this 1/4 century of research has provided very powerful evidence that suggests that pain catastrophizing is one of the most important determinants of your pain experience and also your pain outcomes. And I'll list just a few here. Pain catastrophizing is associated with greater pain intensity, not too surprising there, but it also predicts your response to medications, to opioids, to your multidisciplinary pain treatment. So whether or not you're catastrophizing is going to determine how well you respond to the treatment that your physician prescribes. It also predicts a longer length of hospital stay. We can predict this, how your mind is influencing your body. And it is also predictive of the development of chronic pain after surgery. So very powerful. It can determine whether or not you even acquire chronic pain. It is implicated in the transition of pain from the acute to the chronic phase. Now we can image pain catastrophizing. We can put you in an MRI scanner and we can see what happens. And what we see happening is that when we scan people, that catastrophizing is really associated with those same areas of the brain that are focusing on the attentional aspects of pain and the emotional responses to pain. So not too surprising. In terms of the mind-body connection, pain may be the best example for how our thoughts and our emotions influence our sensory experience and indeed our treatment outcomes. So the way I like to explain it to my patients is, here's your pain and it's just a campfire and it's always there in the background. Sometimes the flames get a little bit bigger, but it's pretty static overall. Then you catastrophize, and here's what happens. You literally grow pain. It's like pouring a can of gasoline on that campfire, and you do this yourself unwittingly. No one wants our pain to be worse, but we need to be mindful of how powerful we actually are, and I believe that women are actually more powerful in this regard. So I have more to say about that. So mechanistically, we see this at the neural level, but also there's other ways in which it may work, and this is through inflammation in the immune system. There's another 1/4 century of work showing that stress has a powerful influence on the immune system. If you're experiencing stress, you'll get this bump in pro-inflammatory cytokines. We can measure them in your blood. If you have pain, you also have an increase in inflammation in your blood because pain is stressful. I mean, anyone who has chronic pain can attest that it is a stressful experience, and in fact, it may be one expression of stress. Now, this was incredibly interesting to me. specifically around catastrophizing because I'm a pain psychologist. So I designed a study where I took a bunch of people with chronic pain and I had them catastrophize for 10 minutes. And then I looked for changes in their blood over the next few hours to see whether or not we could find an increase in inflammation. And what I found, in fact, was that women were better at catastrophizing than men. And this is a whole separate talk, but I'm just giving you the highlights. Women were better at catastrophizing than men. And their level of negative emotion related to catastrophizing was directly linked to inflammatory cytokine expression subsequently. So my personal belief is that women do have a stronger mind-body connection and that they may be more sensitive to factors that influence pain and sensory perception. So in general, the consequences of psychology appear to be greater for women in general, and it appears, I'll say a little bit more about this, but the type of stress may be different for men and women in terms of its impact, and women do appear to be more attuned to interpersonal stresses than are men, and the consequences of stress are greater for older women. So the take-home message is that men and women alike have pain and stress, but again, the consequences of stress and pain are greater for women. So what are we going to do? I'm sorry. Okay, so what are we going to do if we're not going to be focusing on taking pills? How do we reverse this so that we're optimizing the mind-body connection? And the first thing to know is how do we reduce suffering? We want to shape the neural circuitry and get it going in the other direction so that we're decoupling emotion and cognition from pain. And so we begin by shaping appraisal. We want to learn how to change the channel in our brains, basically. And I think that Shakespeare said it best, nothing is either good nor bad, but thinking makes it so. And indeed, it's not the event itself that's important. It is our interpretation of the event. It is our appraisal of the event. It's the meaning that we give events that determines what happens to us neurally and biochemically. And this is really critical. Now, it's hard to imagine pain being a good thing, but the least we can do is help ourselves put down that gasoline can and bring ourselves back to neutral as much as possible. How do we do this? The relaxation response is one way. How do you learn the relaxation response? There's lots of CDs available on the internet. I will give you some links to some free resources, but basically when you're in pain and when you're in stress, you have a physiological response to it. There's neural circuits that light up, your breathing becomes short and shallow, your muscles tense up, your heart rate increases. We want to reverse that and get that going in the other direction. This is basically just a learned skill. You know, you might have learned this in yoga or in other places. This is literally medicinal. And so find a resource for this and use it. Meditation and also mindfulness-based stress reduction. These three have shared mechanisms, and the underlying idea is to bring yourself into a state of observance and non-judgment in present time with whatever is, even pain. Cognitive behavioral therapy can also assist with this, and so work with a pain psychologist to learn skills to help you do this. This is literally learnable. These are some of the outcomes for how they benefit you in terms of mindfulness and also meditation. A lot of people think that meditation is a really difficult skill. This particular study showed that 80 minutes of practice spread out over 4 days trained people how to reduce their pain intensity by 50 to 60%. Cognitive behavioral therapy, again, it's just education, and you're going to learn skills. You learn this with a psychologist. It's very effective across different conditions, as shown here. And you can learn these skills, and up to 4 years later, your outcomes are still sustained without medication, without a prescription. So how many more minutes? I have 2, okay. So how to reduce suffering. Okay, I mentioned changing the channel. You also want to reduce your exposure to stress. Think of this as turning down the volume. So you want to be able to change the channel, you also want to turn down the volume. Now, life is stressful for all of us, but we want to learn how to modulate the factors that are stressful for us. And so you may need to make certain life changes, okay? I mean, this is the story people don't want to hear, but it may mean ending certain relationships, changing certain jobs, doing things differently. This is about making those tough changes to recalibrate relationships, your choices, to learn how to prioritize yourself first. This is really the biggest factor with women. And so I just briefly want to... That's great, right? I love this slide. So she has a really good awareness for how relationships influence her pain. And I'm just going to say, I want to end on this last study I did. I observed how important relationships were with pain. And so I did a study that included 500 women. And I asked them about their pain and these different factors. And the sample was 85% women. There were men there. But what I found was that women had greater guilt and fear regarding how their pain impacts other people in their lives. And this guilt and fear, this worry about how their pain is affecting other people, leads them to make choices, leads us to make choices that aren't necessarily very healthy for us. And this can lead us to take more medication. So understanding, teasing apart, what are our choices? First of all, what are the motivations behind our choices? And how do we help best support ourselves so that we're making choices that are optimal for our own health and wellness so that we can be more available for the people that we love? So the last thing I want to say in terms of recommendations, pain psychology, relaxation response, learn meditation or mindfulness-based stress reduction, make changes in your life that support greater peace in your life. These slides, hopefully they'll be made available to you. These are links, free resources that are available. This is all free stuff for you, so you can also email me, and I'm happy to provide resources for you. And lastly, I just want to say thank you for letting me cram it in.
And Dr. Darnell and Dr. Cohen have agreed that they're going to do questions afterwards together. So we can move right on to the next talk. So it's my great pleasure to introduce Dr. Rob Cohen, who's the clinical professor of neurology. He's the director of the Division of Headache and Facial Pain. And in the interest of time, I'll just hopefully get him linked on here and let him take it away, and then we'll have the questions afterwards.
I'd just like to say in defense of my gender, I think we're pretty good at catastrophizing, too. So I was going to talk about sex headaches, which are fairly uncommon, and my wife made me promise I would avoid all of the obvious jokes about it. But Beth, as always, has inspired me, and I want to toss out an option to you and see if you're more interested. I think it would be a really nice follow-on to see how the principles that Beth just discussed apply in a specific setting, obviously headache. I'm a headache doctor. I'm happy to give the sex talk, but I think it might be really interesting to do something different. There wouldn't be any slides. You like that? I think it's a good idea, too. Okay. And, okay, yeah. And we can also segue into questions from that. So I'm a headache doctor, and usually when patients come to me, they've already seen 26 other doctors. They have 35 MRIs under their arm, and they're hoping that I have the secret pill that no one else, for whatever reason, hasn't given them in the past. We call that a locus of control issue. It means that the people who are coming to see me see the problem as something outside of their control, something they have no way of dealing with. And they're hoping that by putting the locus of control in me or in a pill is somehow going to solve the problem. It's tricky because if you say you have control over this, that's going to almost immediately translate into you don't believe me, you don't understand what my pain is about, and it's a real battle to explain that that's not the case. In headache, and we're mostly talking about migraine. Migraine is 3 times more common in women than it is in men. It affects upwards of 30 million people in this country. It costs the economy upwards of $30 billion a year, and that's not in drugs, that's in lost productivity, mostly. So headache hasn't gotten much attention over the years. It's pretty much well, it's a woman's thing, so immediately it goes to the bottom of the list. It doesn't seem to have any outward manifestation. I mean, if you have a stroke, It's not usually very subtle. You're dragging a leg. If you have an infection, well, you've got a fever and you've got all these obvious outward symptoms. But with a headache, you look pretty well, except to people who know you really well. And how do you appraise it? There's no test that we can do. Now we can get functional MRIs and actually see what's abnormal about a migraineur's brain, but it's expensive. Insurance, of course, doesn't cover it. Migraine doesn't kill people. It ruins their lives, but it doesn't kill people. So it's not a sexy disease in terms of what the government's going to fund. Just to give you an idea, there's about 2.5 million people in this country with epilepsy, and epilepsy research is horribly underfunded by the NIH to around $180 million a year. Migraine, I've already given you the prevalence of that, 20, 30, 40 million people, gets about $20 million from the NIH. So it just gives you a sense of how headache has been regarded. And this is communicated to patients. When a headache patient walks into most doctors' offices, okay, so tell me about your problems. Oh, my kids are going to be home this weekend. Go on. Yeah. I mean, it's tremendously time-consuming. We don't have a cure for it. It reimburses horribly. If I want to send someone to a pain psychologist for managing their head pain, most insurances won't cover it. If I want to send somebody to mindfulness training, won't be covered. Massage won't be covered. Biofeedback, I mean, the list goes on and on. Things that there's good, hard scientific data for is simply not covered. I can give you a $30 pill, which won't work too well, but I can't get you to a counselor who will help you learn to manage your pain. So we have this whole body of literature which tells us the best way to take care of patients. We have patients who are used to being jerked around, not to put too fine an edge on it. We have insurance companies and a government that really doesn't pay much attention and give much support to it. So how do we deal with this? Here at Stanford, we're very fortunate because we have Beth and her colleagues in the pain division who see our patients, I'm sure at a financial loss to the department. I don't know. We don't get to see those numbers, and I actually don't want to know. But out in the community, you can't see a psychologist in most cases, with most insurances, certainly with Medicare, and get reimbursed. So how do we deal with these patients? When I see a headache patient, I start out, and after we've gotten the history and I've done my job to convince them that I'm not disinterested, that I'm not disbelieving, that I'm not the monster that they come in assuming I am, I say there are 3 components. So there's what to do when you get a headache. You know, your head's pounding, you know, now's not the time to talk about your childhood. Now's not the time to, you know, improve your lifestyle. Now you need rescue. So there's the rescue component. Then there's the prevention component. For people who come to medical attention for their headaches, they usually do need some kind of a preventive medicine, by and large. The preventive medicines are not home runs for most people. By and large, they'll reduce most people, any one of them will reduce most people's headaches by about half. And by most people, I mean about half of people. So it's not great. And then we come to the third part, and the third part is where the money is. I can tell you after doing headache and really nothing but headache for almost 30 years, the people who do the best are the people who take the lifestyle changes seriously. The people who begin to address the issues that they do have some control over. The big mistake most people make is they don't pick their parents carefully. It's genetics, you know. And that's important to know because it means that, A, the headaches are not your fault, and satisfyingly, they are your parents' fault in almost all cases. When we get a patient who doesn't have a family history, we need to look more carefully and make sure we're not missing some other diagnosis. It's pretty unusual to find someone, with the exception of people who've had closed head trauma. So about half the people coming back from the war theaters have headache that looks for all the world like migraine, but they didn't leave with headaches. And that kind of underscores what Beth was alluding to, and that is how our brain processes pain. So what's the purpose of having pain? Well, pain is an important protective mechanism. Pain is what tells you that you probably should take your finger back out of the fire, you know. And if you think about it, what is the usual response to any kind of pain is withdrawal. You step on a nail, you pull your foot off right away. Your hand gets too hot, you pull it away. When your environment is hostile, what do? You withdraw. You go to the least stimulating, the least potentially aggressive place you can get to. In migraine, that's usually a cool, quiet, dark place. You're not going to be assaulted by sounds, which hurt. You're not going to be assaulted by light, which hurts. You're not going to be assaulted by movement, which hurts. You're not going to be assaulted by temperature. Basically, all our senses, we need to shut that down. So what's wrong with migraineurs? Why do they have that? Well, it's like the gain has been turned way up, or way down, I get confused, on your sensory perception, how you process sensation. So there are people who are born with no pain perception. It's called congenital insensitivity to pain. I don't know who makes up these names. But these people don't live long. They usually die in the very first few years of life. And what typically happens is they'll just step too hard. They'll get a hematoma developing in their ankle joint. It'll get really bad. They won't know because it doesn't hurt. It'll get infected, and they die in infancy usually. At the other end of that spectrum is us migraineurs, and we don't know exactly when a sensory stimulus is dangerous. So, well, how many people in the room get migraine? Oh, come on, there's more than that. Okay. So, those of you who don't get migraine, I can give a migraine to. And not just by talking. If we go up to, say, 12,000 feet altitude, start skiing aggressively, you will get the same headache that us migraineurs get just going over a mountain pass. If you're not a skier, we can go camp on the big island of Hawaii for a while, a little too close to the volcanoes. And those sulfur smells will give you the same headache that we get when we walk into the wrong entrance of Nordstrom's, smell the perfumes. Okay? So it's a question of the gain. What's dangerous to us? What's enough to make us withdraw from the environment? And it's not just the external environment, it's the internal environment. A couple days before your period, your estrogen levels plummet. It's not that they're high levels or low levels, it's the change. Your brain is trying to process a change, whether that change is in barometric pressure or estrogen levels or gastrin levels when you skip a meal or cortisol levels when you stay up too late or you sleep too much. Your brain doesn't know how to process that as safe or not safe. And so it tries to withdraw. And that's, at its heart, what migraine is about. So what do? Well, there's not much we can do about barometric pressure changes. Although I did have a patient about 6 months ago move to San Diego after doing a thorough literature search and found that the least barometric pressure change was in San Diego. And so I haven't heard how he's doing, but he actually moved in hopes because he was absolutely convinced that barometric pressure changes. But you know, there are some things we don't have control over, and those things are going to give you headaches, and we just have to realize that. But there's a ton of things that we do have control over. We have control over our sleep cycle. We have control over when we eat. We can have control over our exercise levels, and it's exercise that sets your endorphins up. We have control over how we deal with stressful situations and how we view the world. I can't tell you how many patients I see, and I always ask the question, so given that assume I have the pill that you think I have in my pocket, and I give it to you, and tomorrow, for the first time in 30 years, you have no headache. What are you going to do? I can't tell you how many people look at me blankly and have absolutely no idea. They cannot conceive of a world without this constant pain. That pain has become the nidus of their universe. It's the center of, they build their days around their doctor's appointments. They make decisions based on the likelihood of whether they're going to get a headache or not. And I'm not dissing them. I mean, I've done the same thing, especially if it's something I didn't particularly want to do in the first place. But the problem with that is that you end up never doing anything. You don't get out of it. My daughter has given me the expression, fake it till you make it, which at first really bugged me. But the more I thought about it, it's kind of what I ask my patients to do. Now, I understand that you may not be able to go out and get 20 minutes of exercise immediately because 5 minutes of exercise is going to kill you. But maybe you can do 3 minutes or 1.5 minutes, you know. I understand that sometimes your head pounds to the point where you need to get into bed, but maybe instead of getting back into bed and all that's associated with bed, maybe the thing to do is get up at 7 as if that's when you want to get up. And if your head starts hurting, you go to the couch. You know, you don't lay in bed and play with your computer or watch TV because you're afraid that if you get up, you're just going to end up having to get back into bed. If you have to get back into bed, that's okay, but at least you make the effort. There was just an essay on migraine.com, which is a patient headache site. She was just furious about this quote from Yoda in is it Star Wars? Something to the effect that there is no try. There is either do or don't do. And she was furious because she says, of course there's a try. You know, if you don't try to get out of bed with your head pounding, then you never will. And that try counts, and that try has validity. So we need help to do that. You know, we need, often it's just someone explaining to you. I mean, that's really what CBT is. It's talking, trying to give you a perspective or help you come to a perspective that's different than the one you came in the room with. It's not ever implying that you don't have an actual source of your pain, but how we process the pain is just a world of difference. From catastrophizing and building your world around your pain to seeing your cup is half full and going for the things. You go to the movies, and if you get a headache, so you go home. At least, you know, you got 10 minutes of the movie or a half hour of the movie. Making these decisions to get that locus of control back to yourself as much as you can is really the heart of how we treat headache. It's not about a better pill, although we look for better pills. It's not about finding a medication whose side effects will actually help you rather than make you fat, bald, and stupid. So that's kind of the application that we see, and that's where we put most of our energy. It's not a matter of just spending, are we done?
Well, you have time for questions.
Okay. It's not just a matter of looking for a medication and, oh, if the medications don't work, then we have to go to plan B, which is behavioral therapies. Behavioral therapies are what work best in people with chronic pain, particularly when we don't have a cure. So that's my story.
We actually only have about 5 minutes for questions, but I think between the two of them, you probably can come up with some great questions.
What happens when people get scared because they're having cognitive impairment from chronic headaches or chronic pain, and that kind of freaks them out, so it creates the direction towards the catastrophizing? How do you respond to that? You say, oh, it's only an hour a day. You should recognize when you can't remember something that's valid or whatever.
So I think the question is, how do you address fear and anxiety related to pain, whether it's a headache or something else?
And cognitive deficits, because when I talk to people who have those issues, they find that sometimes there's a part of the day where they're scared because they're academics and they can't remember things or write things or function.
Okay, so just to be clear, these are people who have cognitive deficits? Sometimes. From
chronic pain or headaches.
Okay.
Or from their medications.
Or from their, well, I don't know.
Yeah. So one of the most important things is first of all to identify the pattern. You know what it is and what's happening. That a person is indeed having these responses, the fear-based responses, and that the responses themselves are actually what's triggering the cascade. And so this is where a lot of the education distinction in cognitive behavioral therapy for pain comes in. So it's really like everything's really scary until you can pick it apart and look at the pieces and name them and understand, okay, so this is the cascade and here's how it works. And so identifying that and then giving people tools to be able to manage the fear or anxiety that comes up. So learning how to calm your own nervous system is critical. And so we teach these skills, and I teach people to really become proficient using these skills when they're not in a pain crisis or in a fear crisis. Then, when you are in that crisis, you can go on autopilot and you can learn how to calm your own nervous system so that you're removing the overlay of your reactions to the situation. You're still going to be left with pain, right? But pain, that sensory experience, is infinitely more manageable when we haven't poured the can of gasoline on the fire. Then we can sort of just be with the pain for what it is, and we can think more clearly and make better decisions about how to help ourselves and what needs to happen next.
Yes.
How often would you say food allergies are associated with migraine?
Rarely. So I'm sorry. How often are food allergies associated with migraine? So if somebody walks into the room and says, boy, every time I eat pine nuts, I get a headache, I'm not going to argue with them. I'm going to say, don't eat pine nuts and ask for my $300 and, be on my way. But the elimination diets and all of these things, they've never been validated, and they keep cropping up about every 20 years. The new one is this 1, 2, 3 headache cure. These are things that have been re-examined and re-examined. Elimination diets rarely are productive, and very few migraine triggers are absolute. They are mostly additive and partial. So the combination of a bad night's sleep and a glass of red wine might give you a headache, whereas either one alone may not. So education, becoming aware of that, so if I've had a bad night's sleep, maybe I'll pass on the wine with dinner tonight. Being equipped with that kind of information, empowers you. It allows you to make decisions that will have a positive impact. If you know that loud noise is a big trigger for you, but you got 2 tickets to Barry Manilow, you can't pass that up. So you pre-medicate maybe, wear some earplugs. If it really is Barry Manilow, some really big earplugs. And you go and you go to the concert. So triggers are a bit overemphasized because we always think of them as being absolute. And oh well, I did have red wine that one night and I didn't get a headache, so maybe it's not a trigger. Or I got that really bad headache when when the doorbell rang. I got to get rid of that doorbell. You understand?
One more.
What about vitamin deficiencies? Is there some vitamin deficiencies that you see that are causing more pain? You recommend?
Yes, of course.
Well, overall, vitamin deficiencies. So overall, the literature suggests that vitamin D3 deficiency is across the board. If you have a chronic pain condition, you should be checked for that because it's a primary influencer of the immune system and does have an impact on pain. And also for neuropathic pain, look for a B deficiency, and that's a frequently a player. So they will. B2, and so those two just right off the bat are things to look for deficiencies.
And I would just add magnesium to that list and coenzyme Q10. Those are the ones that have good data behind them. CoQ10, coenzyme Q10.
Is there a test to see if the levels are right, or are you just advocating it, taking it?
Both. Given how safe they are and how expensive the tests are, most people just say take it.
Well, let's take our break and be sure that you're in